Hello, my name is Belina Yi, and I'm honored to present our project Sensitivity and Positive Likelihood Ratios of Myositis-Specific Autoantibodies with Specific Clinical Features in Juvenile Dermatomyositis in a large real-world multi-site registry. I am presenting this project on behalf of the CARA JDM Therapeutics Workgroup. Myositis-specific autoantibodies, or MSAs, are associated with distinct clinical features in juvenile dermatomyositis, or JDM, and are increasingly being used to tailor treatment. However, pairwise associations of MSAs with specific clinical manifestations in real-world JDM cohorts remain understudied. Therefore, we conducted this study to determine the sensitivity and positive likelihood ratios of MSAs with baseline and follow-up clinical features of JDM in a large multi-site registry. Patients with JDM enrolled in the Childhood Arthritis and Rheumatology Research Alliance, or CARA, registry between January 2019 through June 2024 were included. The CARA registry is a North America-based international observational inception cohort registry. Sensitivity and positive likelihood ratios of MSAs for clinical features were calculated for those with more than 2 observations per MSA group and MSA groups with more than 5 patients. Significant positive likelihood ratios was defined as more than 2 and 95% confidence interval greater than 1. Results. Out of 303 patients enrolled in the CARA registry with JDM diagnosis and tested for at least 1 MSA, 141 patients had 1 positive MSA, and we did exclude 16 patients who had more than 1 MSA. MSA testing was most often performed at the Oklahoma Medical Research Foundation located in the US, and those were 35%. The most common MSA was anti-TIF1 gamma, 33%, followed by NXP2, 29%, and MIA2 and MDA5, both at 17%. Overall, the MSAs were poorly sensitive, ranging from 5 to 70% for specific clinical features both at baseline and follow-ups, as noted in Figure 1. Significant positive likelihood ratios were observed in the following, as in Figure 2, V-sign with TIF1 gamma, dysphonia with NXP2, interstitial lung disease, arthritis, and skin ulcer with MDA5. Of note, positive likelihood ratio for calcinosis with anti-NXP2 were not significant. So we did look more into calcinosis in our patient cohort. Out of 38 JDM patients with calcinosis, which is about 9.5% from the total cohort, which is around 400, 11 patients were scored for their calcinosis severity in 0 to 10 scale, which is shown in Table 1. One patient with highest score, which was 5, although the score did range from 0 to 10, had anti-NSB2. However, one patient with exoskeleton whose severity was not scored has anti-TIF1 gamma. Strength of this study include large sample size and multi-site data source, although insufficient follow-up data to assess progression of features and variability of MSA assays with potential antibody status misclassification remain limitations. Our conclusion is located at the top of the poster. Myositis-specific antibodies had overall low sensitivity for specific disease features in JDM, with anti-TIF1 gamma, NXP2, and MDA5 having significant positive likelihood ratios for a few manifestations. We do believe that future studies linking MSAs to distinct clusters of disease manifestations in JDM may enhance understanding of their clinical relevance. Thank you for listening.